Okay, so welcome back. I think I didn't lose a lot of people for the second session. So we're going to talk about the safety aspect of TMS. So I selected this phrase because I thought it was very adequate. Safety brings first aid to the uninjured. So actually, in my experience with TMS, I didn't have any big problem, but I did have some experiences. I am not sure if I didn't have any big problem because I tried to be very strict with what I was taught it should be done. And so I will encourage you to follow strictly the safety guidelines of TMS. So in the past, when there were no guidelines, there were some issues reported, seizures and things like that. But after the first set of guidelines were reported, so this diminished a lot. So I think they are there for something, so it's good to have them. So we are going to talk in this session about terminology, safety concerns. So like, okay, what people might, what could be the concerns, some risks, and you need to know because you need to explain this to the people, right? How you select the participants, patients or healthy, and what about the dosing and some ethics and regulation. Some terminology. We have talked a little bit about single pulse, but it would be good that you know this terminology because we are going to talk about it. So these are some TMS terminology. So single pulse, you know, is just the pulse that is delivered by the machine. And per pulse is the two pulses separated by a certain interval. I love that technique because it's so reproducible, and I like everything that you can reproduce, like you say, okay, yeah, it works. So per pulse is another methodology, TMS method. Repetitive TMS is when you deliver different pulses. So pulses delivered in trains. It could be conventional or pattern. Conventional are these offline protocols normally that is regularly repeated single TMS pulses at a certain frequency. So we have the low frequency paradigms. Low frequency is for all the pulses that are delivered 1 hertz or less than 1 hertz. So 1 hertz is 1 pulse per second. So everything that is sent to 1 pulse per second or less than 1 pulse per second than the low frequency, right? So I mean, yeah. So then we have also the high frequency that is greater than 1 hertz. So 2 hertz, 5 hertz. Well, the more typical is 5 hertz, 10 hertz, 15, 20 hertz, 25. So it means 10 pulses per second. And so everything that is higher than 1 hertz, than 1 pulse per second, so it will be high frequency. So this is for the conventional protocol. And the pattern will be like the repetitive application of short high frequency repetitive. So mixing a little bit the high frequency part, but like sending in short bursts, like in patterns. I send 3 blocks here, and then 8 seconds later, three blocks, and then 3, and then something like that. So refers to repetitive application of short high frequency RTMS burst interleaved by short pulses of no stimulation. So why I'm saying this, probably because during the talk I'll be saying, okay, yes, for RTMS, for TMS, the safety guidelines are a little bit different. Because with single pulse normally nothing happens, but with RTMS you can cause a seizure. Yeah, so that's important to know. Safety concerns. So what are the concerns when I'm applying TMS? That it could be tissue heating, like you are applying this on a repetitive and then it will get warm, or forces and magnetization, or maybe you will induce voltages, or due to magnetic field exposure that we were talking before, also like people use this these bracelets or salts. And haven't you seen these people that they, some persons that they are afraid to use the microwave, or because they don't want the food to be exposed to the electromagnetism in the microwave, or they don't want to have the cell phone at night closed because maybe something will happen. Maybe their fears are real, I don't know. But it's also this thing like maybe magnetic field exposure would be harmful for the experimenter or for the people that are being measured. And then we'll talk also about TMS and implanted stimulating recording electrodes. So safety concern about tissue heating. Tissue heating due to single pulse TMS, well, it will not happen because it will be less than 0.1 Celsius, degrees Celsius. You know what I mean. So it's actually no really hot single pulse, no, that is really harmless. Yeah. But the problem is when you have implanted electrodes. So if you have electrodes that are implanted, so actually TMS can cause some temperature increase. Yeah. So, but we are not going to work with implanted electrodes, right? You are going to work with healthy people. You know, implanted electrodes, people that have epilepsy or whatever, and they have some electrodes that are implanted. So we are not going to work with these participants or patients or whatever. But anyway, I thought it was good to mention it. So in this case, when you have implanted electrodes, they will need to use low conductivity plastic electrodes. It will be better. And before doing any testing for when people have implanted electrodes or whatever, the good thing is to test ex vivo. So you do some testing outside just to check that things go right. You need to measure. Actually, it's quite interesting when in the lab where I'm now, in the department, there is a group that works doing coils and all this, like they design the coils. And it's very interesting because I talk to the people when they are doing the test. They are testing temperature, sound, and all this kind of stuff. So they need to check that how the coil overheats and all this kind of stuff. So when you are doing your experiment and you have these kind of special conditions, you also need to test how things will come. And then when you do, you need to report the results of this testing so that everybody knows what did you get, and then I can also use it for my research. Forces and magnetization. So magnetic field pulses is attractive to ferromagnetic objects, right? If I have something magnetic and I have a magnetic field, so it will feel some force because it's attractive. But it's repulsive to non-ferromagnetic conductors. So the problem here is when we need to check that, and it's part of the questionnaire. If you have implanted things in your head or whatever, because you should not measure people that have implants over the head, in the head, because TMS exert forces there and can displace them, so it can move them, and that's very bad. So you should take care of it. It's very important that you ask people. This is a safety concern, right? And you see in the questionnaire, it asks about it, right? When you have a yes, you need to ask what exactly it is. Some titanium scope plates may be safe for TMS and even for MRI or things like that. But anyways, I wouldn't run any risk. I normally, when I have a doubt, I do consult the doctor associated to the study. Anything I don't know, I always ask, and ask someone who is higher than me in knowledge this type. So I'm safe. If the doctor said no, I said no. No question about it. Obviously, I ask for an explanation, then I learn. But in any case of doubt, in your studies, you should always have, it's good. I have always had a doctor associated to my study. So I would recommend the same to you, because it will really help you to get clear in many things for people that would be suitable. Obviously, the doctor needs to know about TMS, right? So I will really recommend that, because it will get a burden off your back. when you have someone to consult and to ask what is appropriate and what not. And you will have these situations when people will come with certain situations that you don't know, that you have the list of things you should not follow and you don't know how to answer. Same thing when you have people that have some implants, so you do the ex vivo testing and then you check how it works and then report also the results. This is very important, at least I say in what I think. You should know when I'm doing TMS, I ask the person to remove all the jewelry or everything that they have. I know some people that don't mind doing like with piercings. I don't do it. In the safety guidelines, it said you should not do it. In the manuals of the machines, that you should not do it. So don't do it, because it will. I was talking to a company, to the company we're working with, like from the machines some days ago, because of one of these issues. No, I didn't want to measure someone with the piercings. I have never done it, but I wanted to know how were the regulations. And he said everything that is 30 centimeters close to the point of stimulation should be out of question. You don't measure that. Not because then you say, yeah, but it's far and maybe it will not happen. No, don't do it. You know, like just because the logic says that you are far enough, don't do it. Because if the rules are there, it's for something. And this is something that is very common, because you will measure probably a lot of young people, and a lot of young people now have a lot of piercings, and some of these piercings cannot be removed. Or they need to go to be removed in a special place. Ask them to be removed. If they cannot remove it, so just don't measure. That's my suggestion. Okay? So jewelry, glasses, watches, or any potential conducting or magnetic objects worn on the head should be removed. You don't want to cause any harm to this person, okay? Induced voltages. TMS can induce large voltages in nearby wires and electronic devices, so you don't want to have your cell phone or whatever near the TMS code. When you are doing your TMS, everything should be like empty. There should not be cell phones or whatever near. Cell phones should be removed. Everything, as we said before, everything empty, metal-free, device-free, okay? TMS can damage the internal circuitry of electronic implants near the coil, causing malfunction. So anything that is implanted, you should really keep an eye on this, because TMS can damage it, okay? Say things about implanted electrodes. If you are working with patients, and TMS has been done with patients that have implanted electrodes, but obviously you should do it, testing it before. There is a lot of knowledge about it, but there are studies that have been done. So anyways, you are not going to do it, but just keep an eye on that and ask for expert opinion and testing before doing some experiments. TMS should only be done in patients with implanted stimulators if absolutely necessary, and you should follow a strict experimental protocol that have been accepted by your ethics committee. Fortunately, I think here is the same. You need to present your project to an ethics committee, right? So there is an institution that will approve here in the university your project or not. Is it true or not? Like an ethics committee you have here? So fortunately you have that, so they will be keeping an eye on you following the right procedures, right? Because sometimes some scientists, just to do some research, they don't care, and then they create some crazy stuff. So fortunately there is an institution or a part of the university, of the research community, keeping an eye on that, and that you are not doing whatever you want. For people that have pacemakers and spinal cord stimulators, and there is also a question in the TMS questionnaire. As long as it's not applied over the area, so it's fine. I wouldn't measure it anyways, unless I have to. But if I don't have to and I'm working with healthy subjects, I will definitely only work with healthy. It means like people without any issue, no medication, no any type of anything. Yeah, it's not like he's unhealthy, but definitely is not the normal person walking outside. Magnetic field exposure. It has not been found really like magnetism does any damage to the operators, and my PhD thesis was exactly about how electromagnetic fields and magnetism in general affects living, and we didn't find anything, but I wouldn't, so obviously this was not like exposure for years and years and years. It is not known, but then as a safety guidelines in one study that was done, it says that the distance to keep when you are operating should be 0.7 meters from the surface of the coil. I'm not sure if we follow that, 70 centimeters. And yeah, it's not known if using the coil will do anything. I don't think so. I've been 10 years using it. I'm still here alive, and I think a little bit in my sense, right? Like I'm still cognitively fine, so I don't think unhealthy. So I don't know, but I wouldn't say nothing happens. But there is research that is needed to do in that direction, right? But then you will have these people will be scared of it. There is not known risks, but then you never know. Now we talk about the risks. I'm going quite fast actually, but okay, it's good. This is really the part that you really want to know, because you want to emphasize this during your when you are talking to your participants. So there are several risks that will be hearing, headaches and local pain, migraines also included in the headaches, syncope, seizures, cognitive changes, and I put actually psychological changes. Hearing. So as you know, the TMS makes like a click. Have you heard before? So you will hear in 1 hour, in 30 minutes later, you will hear that each time you send a pulse, due to the force that the mechanism, so the pulse will deliver like a click. So if you increase the intensity, the machine output, the click will be stronger. If you are stimulating constantly, so you will have this click, click, click. Some adults have reported that they have a shift in the threshold after TMS. I think could be likely. I think I have some kind of tinnitus somehow, like this beep, probably for TMS. I'm like, oh, maybe I do have. So some people have reported tinnitus as well, and then in one case, a participant not using earplugs and with an H coil. Remember I showed you this H coil that was so strong. Has a permanent threshold shift of audition. So it's quite important that I don't use it myself, but in our lab, everybody uses earplugs. It's compulsory. The person who is being seated there, being measured, and the operator also will be good to do it, but the person who is being measured should use earplugs. And I asked there, what if they don't want to use it? So you don't measure. Okay? So there is.
I want to ask a question. So any earplug is okay for them, or there is a specific one?
No, earplugs. The ones that you put inside and then they expand. So consideration before, during, and after a TMS experiment. You know, there are some individuals that have these cochlear implants, so they should not receive TMS. It's the same thing we talked before about the TMS implants. Like it can cause some damage, or it can remove, or it can move or shift, or whatever. So as there may be many interactions between the pulse and the equipment, so individual with a cochlear implant should not be measured. Of course, it has to be, you need to consult this with your doctor. It's not a decision I will make. If you are going to work only with healthy subjects, again, only work with healthy subjects. Healthy is healthy. like free of problems. In which cases you can apply, although the person has a pathology in the, with the hearing, when the RTMS is being used for tinnitus treatment. So in that case, you could use people that have problem with tinnitus, for example. You can use RTMS on person with the problem with hearing only if this will help them to improve their audition, okay? So as I said already, participants should use earplugs or earmuffs during the TMS session. Participants complaining about hearing loss or oral fullness or tinnitus must be immediately referred to auditory assessment. If you have a subject that is complaining, no, look, I am listening like some bells or whatever, like this, like a, you know, so it should be referred to a doctor immediately to check what happened, okay? So when you are doing your assessment to bring participants here, you need to tell them that this is a possibility, not scare them. You are going to have this problem in your ear. No, but you need to tell them there is a possibility that you will have this problem. So someone was asking me, what if they lie? I'm not sure I would lie in this case. If I'm listening all the risks, would you lie? No, I think I will not come on. People normally cancel. When they are scared of something, they will cancel. They will not come to the session. So I very much doubt they will lie. Another thing about hearing is about healthy children. It's not known what can happen, but it's not recommended. It's not recommended because they are still in development, and it's possible that the TMS causes damage in the ear, and we don't know, but as we don't know, you should not do it. So you will use RTMS, and RTMS is actually quite delicate because the brain of the child is really in development, and RTMS is doing something, is modulating. You're applying a stimulation for 15 minutes, 20 minutes, 30 minutes. You don't know what you are doing, and the brain of the child is not completely formed yet. I wouldn't do it to my kid. I don't have a kid, but or my niece or my nephew. I will really think twice, and I will do it only if it is necessary. But you don't know what can happen. You don't know what you can do to this person, so I wouldn't do it. So due to the potential risk, it's better not to do RTMS in children. Single pulse and per pulse protocols, so 2 pulses or 1 pulse, have been shown there is no risk. But RTMS protocols, which are modulatory, are not accepted.
So can I ask, is it healthy children? Is there an age limitation, because there are RTMS services in China applying on children who have substance abuse and gaming disorder. So would you say there is an age limit that?
Well, we are talking about healthy child, right?
Healthy.
But be healthy. For patients, is different. I don't know if I think I have some slides here. Like, depending on the type of study you have there in the safety guidelines, you have like 3 types of study. One that is for patients, like type 1, I think is for patients when the benefit is higher than the risk. So if you are applying a therapy, and the benefit that the person, child or an adult, can receive from this treatment is superior to the risk, so you apply it.
Do you still have an age limit?
I guess for child, I don't know, because I work with children with pathology, with anxiety, and we were doing some tests for depression, but it was not for RTMS, it was just single pulse and per pulse. I think studies with children there are not many studies. In Germany, there are some labs that are doing that, but I was reading a paper, I think they were talking even about babies. So I'm not familiar with the literature for little babies. I know we were working with patients that were 7, 8, 9, 7 to 12, and yeah. But we were not allowed to do RTMS, of course, and for healthy and even single pulse, we were not allowed. Only with patients. We could only work with patients. And I guess the people that are working with our TMS, they have sent the therapy protocols or research protocols to an ethics committee. We should keep an eye on this, right? But yeah, so the benefits should be higher than the risk, because actually you could damage their auditory system, so that's important. Although it's theoretical, no? Okay, headaches, migraines, and other pain things, like could be neck. No, people complain about neck pain. Not in my case, I have never had this situation. Headaches, I had just one case, I think, or two. I will tell you that story later. And migraines, I haven't had the problem with migraines. There are studies that use RTMS or stimulation for treatment of migraines, and then it's a treatment, so it will work. So single pulse is generally well tolerated. So you send a pulse and you wait 4 seconds, 5, 10 seconds, and then the next pulse, so it doesn't cause so much headache. But RTMS can be painful, and it can be painful, really, depending on the area you are applying. It's just really, really uncomfortable, and it depends on the threshold of pain of the people. So I am a coward, and I do feel pain with these kind of things, but there are people that you can apply and they just don't feel anything. So we can do some testing here, and then we see how you feel it. But as I said before, when you are going to do a testing, and if you are suitable for TMS, test it on yourself or in your hand or whatever, just test how it feels, because it can be really painful, and then you can understand what the participant is going to feel when he's feeling the stimulation. So headache, according to this, the reports, headaches and neck pain are the most frequent RTMS effect reported, like around 40% of the cases, they said. It's not my experience. I have been 10 years working on this thing, and it's not my experience like the headache is the highest reported, no. But okay, there are other labs which have actually reported it. And in the papers also you can see that. In when I was working with the children, anxiety and depression, we were reading all this stuff to present to the ethics committee. And in the papers, normally they do report when they had this kind of cases, no? Like three children reported headache, or they complain about this. So if you have these cases, normally you do write about it.
So what are because you said that in your experience that not so much reporting about this kind of thing. So I want to ask, so what kind of areas that you typically research on the cortex?
I have worked a lot, motor cortex, dorsolateral prefrontal cortex. I have done some experiments in parietal and visual cortex. Oh, almost all.
Most of them. So actually, you have done all the areas, but in your experience, it's not very.
The headache, I didn't have the headache problem, and normally my participants came several times, so I did have the opportunity to follow them, to do a follow-up, and I work also with patients, and I didn't have that. Even I remember there was a patient or two patients in multiple sclerosis patients, and we were doing a study, and I did tell them, okay, do you suffer migraines? I think there were two females, and I said, I do have migraines sometimes. So, okay, look, I don't recommend this, but she was a patient, so because I can cause you migraine. No, I don't mind. I want to be part of no, I don't think so. No, it's sometimes and not always, but like once each 3 months or 4 months and blah, blah. And I didn't have the problem with her. So she insisted, because she said it was very sparse. She wasn't diagnosed as a migraine patient. Like she had sometimes, so probably sometimes you have your period and you have migraine, I don't know. Or the weather is weird and you have migraine. So it seems that it was the case, and she didn't experience headaches.
In your situation, you actually, because I know that you work at clinical settings, right? So actually the participants come, they think that they're receiving some treatment, or they just think that they are doing a research?
No,
because in research, they may not have any benefit from it, right?
No, I haven't worked in the clinic. I have worked with patients, but to do research. Okay. So you should, in your consent form, it should be clear that your research is no, it doesn't bring any benefit therapeutically.
Do they have, are they volunteers, or do you have some, give them some incentive? So why they come to the research? If there are so many side effects, could be side effects.
Yeah, I for healthy participants we pay, and when I have worked with patients, they don't receive anything. Patients receive, for example, they have to park the car, so you pay the parking. But for patients, we were not allowed to do any payment. Adult patients or children were not allowed to receive patients. No.
Maybe they just think this is a kind of, in clinicals you have
No.
psychiatrists,
No. That's why it's very important, the consent form. You need to specify, it should say, and when you need to sit with the subject, participant, patient, whatever, and you need to explain what is the study about. You need to clearly state, this is a research project, it should say there. Although our TMS has been shown that it's good in depression, and it's good in this, and it's good in that, you will not get any benefit from it. It should be stated there. Because you need to make sure that you are being clear about this. They cannot come expecting that they will get better at certain thing. So I was very clear, and when we were working with the multiple sclerosis patients, I was working with neurologists. It was a project from neurologist team. And we worked, the neurologist made the test, and then myself, and then we were together, and both of us always give the same thing. It's not for treatment, is for research purposes, and you explain what the purpose is. Obviously, you are not saying what you want to see, right? You don't want to explain exactly the experiment, but you need to explain, okay, we want to collect data just to see how different is the brain from healthy to MS, or, yeah? It's measurement, as I explained before, right? You can measure or you can modulate. So you are collecting data in different levels. And definitely, when it's not therapy, you need to say it's not therapy, yeah? And anyways, in the EPIC and the review board, when you are doing clinical studies, it's treated completely as when you are doing research. They are completely different things. So I haven't done clinical studies.
But there are a number of clinical studies on RTMS as well.
Yeah.
It just happened your research wasn't a clinical study.
Yeah. Yeah, so
it can be a clinical study.
Yeah. She's asking me about my research. I have not.
It's usually for research and
yeah, sure. If you are doing clinical research, you need to say what is clinical and is treatment and this, right? But if it is not, because it's very common, actually, they read this like a normal study, research study, and you need to specify when it's a research study that is not, you are not going to get better. You are not going to get worse. You are not going to get anything. Just we are collecting some data. It should be clear, right? And in I had this situation several times with healthy participants, teenagers, like 19, 20, 21. They knew they have MRI or something like this or TMS, and they came and then they were expecting me to tell some diagnosis or whatever. I'm not a doctor. And you have this kind of situation. So you need to be clear, like, no, this is no diagnosis, this is no treatment, nothing. And it should be, they should read the consent form. You have your form, and it should be the, Alex just showed me this, that one page. No, that one page form cannot be a consent form. The consent form should be quite specific. You need to say what TMS is, what the risks are, what is the purpose of your study, what they should expect. They should expect not to get better or anything. You need to be very clear, yeah? When people have headaches, like I said, it has not been my case, but maybe other people have had this situation. You can provide just an Advil or an analgesic for the pain, and it will pass. It's not permanent. It will pass. It could be for many reasons. You have some people that they are more susceptible to believe something will happen, and then they will have the impression that something happened, but didn't. And I did have this experience. And then just they take one pill and that's it. Yeah. But I wouldn't measure the person again if I know has headache or whatever. If the person reported something strange, I wouldn't measure the person again. I would prefer not to. But it's just my opinion. Other type of pain reported are toothache, but it goes quickly. What you will, that I have seen is like I have said before, when you stimulate the frontal region, you have this thing here in the like it contracts your facial muscles. It's quite painful, I find it. But people bear it quite good, and then once you don't stimulate, it passes. It's not like stay there, but you feel the pain there, and yeah, you can bear it or you can stop the study. No migraine attacks have been reported after RTMS, neither in normal nor in migraine patients. That has been also my experience. I haven't had the problem with migraines. Same, so what I was saying now during therapeutic RTMS, because in therapeutic RTMS there are many sessions, right, that you're applying during several days, and you use like long sessions or what, depending on the protocol, then they have reported frontal RTMS, pain due to RTMS, right? That is this thing here because you have these twitches. The protocols have used are for research and are 15 minutes or 25, 30 minutes, and I haven't had the situation. The pain initially, yes, but then it passes. But in the treatment, they use, as it is painful in the beginning, so they try to use something like it's a ramp up. So they start probably with certain dosage, and then they are increasing it in the beginning, and then until they reach the level they want, and then the pain is more is better for the person. Is lower, yeah. But okay. Anyways, if you have the pain, is not permanent. It will decline. You will get used to it. I think it's more that. Syncope. Okay. This has been my experience actually. No headaches, no migraine, no anything. I did have this experience mainly with boys. Yeah, that's kind of interesting. I don't remember if I had with any female, but I had this experience mainly with boys. They are there waiting for them to be stimulated, and suddenly you feel that they are starting like to faint or something like this. It's quite interesting. It's a common experience in TMS, and it's more often than seizures. And probably it has to do with the anxiety. When the person has not done TMS before, and they have read about it or something, they come with anxiety, and believe me, this is very common. So they are uncomfortable, and they just start to see everything black. So the main feature that differentiates syncope from seizure is that it's very rapid. The recovery is very rapid, and it's in a matter of seconds. When you have experience with TMS, you actually can feel it in the head. If you are holding the head of the person, you feel that the person has like a loss of tone when the syncope is happening. Like you feel it's different. And my experience is the boys normally, they will not tell until you ask them. They're like, are you fine? No, I'm not fine, because you can feel it. You can feel that the person is not there anymore. The tone of the body is not there anymore. The seizure lasts longer, and I have never had a seizure, thankfully. But I have seen someone who had it, but it was not with the stimulation. It was just, they were going to stimulate and before, so it was not TMS related. I don't know why it happened. So it's very important that you learn to react in the case of syncopes and seizures. And you need to learn to differentiate, because they are very different. But you need to learn how to treat them. As in my experience, syncope is the most common, what I have had. You really need to learn how to be prepared. Yeah, because if you have the person that suddenly is like, no, they will report. I don't know if I have here so. They say they are seeing things black, and the visual field is narrowing, and they feel dizzy, and then it's very hot, and they need to breathe, and they start to sweat, and then you see it's like real effect, and then you see they can become pale, and they have nausea. So what would you do in that case? What would you do? You will go running and
First, stop the experiment first. then let the person feel easy, maybe just go take her to another seat and then calm down. But we still maybe need to call somebody, right, to check.
So first of all, you need to keep calm always. It's very important that before you continue, as I said before you continue to do a real TMS experiment, you need to bring an expert here to teach you what to do. It should be really a practical thing. They need to explain what the difference is between the different seizures that you can have, because it can happen, right? Although you need to be very strict with your questionnaire, TMS questionnaire, like no family with epilepsy, or epilepsy, the person, or seizures, or whatever. You don't want to have that just because you don't want to put at risk the person, yeah? So you need to bring someone who will teach you that and what to do. You need to have also in your lab the emergency numbers. You need to have a doctor associated. You need to know whom to contact when you have this situation. In all my situations, I have except one, I have the possibility always to bring a doctor, always, because I know nothing happens. But it's good that the participant feels safe, right? They measure the pulse, they just check him, and it's kind of cool that they check that everything is fine, and they, in your consent form, it should be stated that they have the right to consult the doctor that is associated to your study if something like this happens, okay? So what I'm normally doing is the person is feeling in the chair, is feeling no good, so this chair I don't know if you can put it like back, but normally if you can put it back, so you allow the participant to lie down, and also, or to put the legs up, because having a drop of pressure, so you want the legs to be up so that everything goes back to normal, and then it will come back immediately. But of course, I'm not an expert to give you an explanation about it. The only thing I can tell you is that you react calm, and then you put your patient in a way that the legs are higher than the head. It will pass in a matter of minutes. Keep calm, bring water, bring a doctor. Don't leave the patient alone, the participant alone. As this is happening, never leave the person alone. Wait until everything passes. If you have two persons there, so one stays and the other go and look for the doctor. In these cases, if it were a seizure or any other thing, you really, really, really need to have in every TMS lab the figures, what to do in these cases, you know, like everybody sees the photos of the figures, what to do first, and second, the emergency numbers. So, because you will forget, right? It could be the number of, I don't know, 2424, and you know it's just 2424. At that moment, you will forget that it's 2424. So you need to have it there, and then you need to be able to contact. So you will tell me, maybe, if you have this experience of syncope, which is very normal, because as I said, people read a lot of stuff on the internet and read stuff, and they come with this anxiety that something is going to happen, and then this happens. Induction of seizures. So this is the most acute adverse effect of RTMS. It's kind of not nice, but after as I mentioned before, after the guidelines, the safety guidelines have been established, this happens very rarely. So as long as you follow the guidelines, this might not happen. I never had this case, so I can tell you that you really need to follow, and then probably will not happen. The percentage will be very low. And the amount of seizures reported in the research actually is very low compared to the amount of research that is being done, including patients. Even they have been studying people with epilepsy, and they haven't caused seizures. There is a type of epilepsy that is very reactive, and then you will cause the seizure. But as I say, in these cases, you will work with a neurologist or an epileptologist, right? You will not be doing research. That is a no-go. If you are working with patients, you have to have a doctor. That is imperative. You can know, and the doctor should be that is available. If you are working with patient population, is for responsibility. You cannot just have a doctor like half an hour from the place where you are. No, it should be available, okay? So following the guidelines, the possibility of inducing a seizure is very, very low. So the seizures can be induced by our TMS protocols in their normal form, the conventional, or the pattern form. It normally can be induced after they are TMS trained or immediately after or during the train. Cognitive changes. There have not been cognitive changes reported. Imagine how horrible it would be. If there were cognitive changes due to our TMS, we wouldn't be doing that, right? Although I have read some funny stuff long time ago on the newspaper saying that some type of stimulation, not necessarily TMS, could make you more, improve your memory, and that was unfair with the students that were receiving stimulation when they are doing the exam period, and the students that were not receiving. I really don't know if it works like that and that it lasts so long, but probably if it does, I don't think we will be here talking about this now. We will be probably doing other type of, I don't know, other type of stuff, or stimulating ourselves to become more intelligent or more, have a better memory. So, but this is a worry that people have when they come to do a study. You will have this, what it will do to me? Will I, because we will see, no, that you can create virtual lesion. You are going to shut down one part of my brain and I'm not going to be able to think properly. No, it doesn't work like that. I'm sorry. We will really like that it works like that, but it doesn't. So you need to explain that. No, there are no cognitive changes. I don't think so. I haven't seen it. Maybe what you could see is like an improvement in reaction time. See if that's good enough, but it will go just for 7 minutes, 10 minutes as much. And so yes, so no contraindications related cognitive changes. When you want to do this type of experiments, you need to check what the TMS train duration, stimulation rate, intertrial intervals, and number of trials, and the session. So when I'm planning an experiment, it's very important that I check how many pulses I'm going to apply as well, right? It's not like I can infinitely apply pulses. No, we don't know what we are doing. So I'm saying, yes, you don't have cognitive changes, but with the protocol that we are working with, but it doesn't mean I can abusively stimulate you for 2 hours. I don't think it works like that. We need to follow certain guidelines, and for that are the guidelines. When you are going to plan an experiment, try to check the literature and what is possible and what is not possible. I cannot tell you here all the possibilities because there are many possibilities. But definitely, you are not free to do anything you want. You need to follow some guidelines. And you cannot have like in therapy, you use daily stimulation, but this is for therapy, right? For research, I don't know if it is that responsible to bring people every day to stimulate them for 1 hour or 2 hours. You need to think about it as well, right? We have some responsibility with the persons we are working with. And the idea is to do science to get some knowledge and not to affect the people because we don't know anyways. So for safety reasons, the combination of parameters is important. With short train durations and long intertrain intervals carrying less risks. So blocks, weight, blocks, weight, blocks, weight would be the best, like long weights, yeah? Psychological changes. So this, they have reported some changes in mood, and they have been reported in patients with depression, some manic episodes, but it's not clear that it's due to TMS or if it is due to just taking part of the study. It's not like controlled, so it's not known really. So there is have been reported like you could have TMS. Well, some are reported clearly and some not. But in all studies, but some few studies, so you need to take this into consideration. If someone reported it, you need to pay attention to it and know that this is a risk, because for that reason someone is reporting it. So it has induced transient psychotic symptoms, anxiety, agitation, and suicidal ideation. But this is for patients that have, for patients, people that have pathology, psychological problems, right? Not for healthy people. So I don't know if I have it here. Yeah. So it goes away once you finish the stimulation, once you finish the session. But it's really important that when you are going to do this type of treatment, well, you work with actually pathological patients, you need to take care with it. You need to observe. You need to inform them that psychiatric patients can have these effects. It's very important that they know, so they can have an objective and very well-informed decision. They can make a good decision about if they want to take part or not of the study or the treatment. The likelihood of having this type of effects that we talked before, ideas of suicidal, to commit suicide or agitation or psychotic symptoms, which could be very impressive, I think, it will depend also on the level of the pathology, right? But it's important that you know that. If this is cumulative, it's not known. But it's important that if you are organized, this should be also in the consent form. So this should be that the person, when they read, they will know that they can have this type of episodes. Knowing this kind of information really will make the subject to lie when they are filling the form. Would you die? I wouldn't lie if I read this. I definitely don't answer. I just don't come if I do have some problems. This is for patient population. But in healthy participants, there have not been reported mood or psychological changes due to TMS. So you will not become happier, or you will not become more sad because of TMS. Although I was reading something like recent, like 2 weeks ago or 3 weeks ago, some type of therapy, it's of the stimulation that will make you happy. I thought maybe I'm not unhappy, but let's try. Maybe it works. Okay, any questions? Okay, participants selection. So we're going to talk about patients, children, and pregnancy. Patients, this is really, really, really important, and also with your healthy participants. Drugs, or this medication or recreational drugs, it has an effect, it interacts with TMS. You don't want to have that, you want to control for that. So the main risk when you are working with patients is the interaction of the drugs with the TMS. Why? Because some of the medication that they are taking will lower the threshold for seizures. As this is happening, you need to take care of this part. What type of medication they are taking. So in each country is different. There is a list, but I didn't bring the list. I was talking to a neurologist before when we were talking about this, and I said, okay, what do you think, the list, blah, blah, and he said, no, you need to tell them. They need to talk to their doctors there, because the medication in Hong Kong and China probably is different to the medication they are using in the United States or the medication they are using in Europe, because there are some medication that is not allowed there, but is allowed here, and you use different things for depression or things. Some will be similar, some are not. So you need to talk to a doctor that knows about this and ask which ones are which medication is not a problem to use with TMS. Is just which one doesn't lower the threshold of seizures. So I cannot give you a list, because you need to make your own list and to know which one will be the ones you need to take into consideration when you are doing your studies. It's clear? So the difference between clinical TMS and basic neuroscience is that patients are being medicated with a range of CNS acting drugs. That's the main difference, right? The healthy subjects normally don't take medication. So this is the other part. What happened with these subjects that are drug addicts or something and you don't know, right? You need to try to take care of this. And in the lab I'm now, we do make drug tests.
So what's the evidence, what class of drug that we have to specifically be aware of? Say, for example, the stimulant, what type of drug?
Yeah, the drugs that lower the threshold for seizure. So any drug that they take that might lower the threshold so that it's easier to induce seizures, that should be something that you should take care of. Right. Which one exactly, I cannot tell you. You need to know which ones here you are using, right? And which medication are the common here. But this is easy. You talk to a neurologist or a psychiatrist or whatever, and they will tell you immediately what are the ones that normally would be, they will have a list. Yeah, antipsychotics, antidepressants, anxiolytics. Yeah. So just you know the list, and then you know, and when you are writing, that's why the consent form cannot be as simple as just one page. And your ethics cannot be just one page. You need to have an exclusion criteria and inclusion criteria for healthy subjects and for patients. And when I am working with my patients, in my healthy subjects, I do have a list of things that they cannot have. They cannot have problems with psychiatry. They cannot have medication. They should not have these kind of things because it's a risk for them to have a seizure. Now, something I forgot to say about the seizures. I don't know if I will say later, but I'm going to say now. The fact that the participant is induced, we induce a seizure in a participant here doesn't mean that now it will become constantly we will have seizures. No. You induce it because probably he was prone for whatever reason, because he is taking medication or because he has some history and he didn't know or whatever. But it doesn't mean he will now every week will have seizures. No. But you need to keep an eye on that, right? That you created a seizure, caused a seizure on someone that didn't have seizure before, and it needs psychological treatment. Of course, you need to send him to a doctor and to take care of their psyche, because it's very impressive that suddenly the person was healthy and suddenly is receiving TMS and had a seizure, and it will be very dramatic for anyone, I think, right? Say, okay, TMS did this to me. No, it didn't. You had it there, but you didn't know. But they need to know this and work on that, right? It's one of the recommendations of the SFT.
Time, like, say for example, you used to take antidepressant, but this week he hasn't taken any drug, or today. So is there a time that is free of drug?
Each time, I'll answer how I take this. Each time I have these cases, which I have had. Recently I had this case. And I asked which medication is and blah, blah. And it was kind of funny because it was a person who didn't want to say he was taking medication. And then I said, okay, you need to read this, the consent form, which was super extensive. And then the person read it, and then I don't know, like at night or whatever, yeah, it was a weekend. Send me a message one day before Sunday. Hey, I forgot to tell you I'm taking this medication. But I don't take it every day. I take it like some days yes, 4 days no. So I say, okay, I'm gonna talk to the neurologist I consult, and I say, look, I have this case. This participant has this thing, is taking this medication. 1 day yes, 1 week no, 4 days yes, right? Don't measure. He said, so you need to consult your doctor. That's what I will tell you that you should do. Because in this case, particular case, he said, okay, the type of medication and this irregularity will make it more unstable. And I didn't want to have that problem, so you don't want that problem. But then every case is different, right? But as I'm looking for healthy participants, it was a pilot. So it was just a pilot. I wanted to pilot something, so I just needed someone to test something. But even pilot, I will not measure this person, no. You should follow the same standard for pilots or for real experiment. Although it's your colleague, or it's your brother, or it's your anybody, you need to follow this. Yeah. So when you have this doubt, like is this continued for 1 week or whatever, and the person is not a patient, you are not doing a patient study, consult your doctor. You see how important it is to have a doctor associated to the study, and no any type of doctor, preferably someone who knows about this, right? I guess gynecologists will know about this, but I would prefer a neurologist, right? Or psychiatrist, or someone who knows about the medication. At least I prefer neurologists. Fortunately, I have always, during all my career, have access to neurologists. Every problem I have, I consult to neurologists. And so far, so good. So, this thing, when you are selecting, obviously here we are talking about patient population, just because I want, in some cases you will work with patients. You always, you need to expect that when you are working with patients, they are taking medication. You need to have this in mind. Don't think, no, but maybe they are not taking it, or no. You need to think, okay, no, not only they are taking medication, but probably they are following other types of therapy. This can interfere also with your experiment or with your treatment. You need to consider this when planning your experiment. Same thing, you were asking what type of medication. I cannot tell you names, but would be antidepressant, antipsychotics, anxiolytics, analgesic, anticonvulsants, as they will interact, increasing seizure risk. In the consensus document, it appears like hundreds of times, exactly the same part. You need to take care of the medication. You need to take care of the medication. So it will appear like repeatedly, okay? So it's really, really important. I think it's kind of good that when you are working with healthy subjects to do the drug test. It's kind of cool because it's also your safety. People will lie, and we have had the situation that they lie. No, with heavy drugs, not that I am, well, I know it has happened with other persons, not in my study, but it has happened with marijuana, right? Well, it will change, it changes the excitability of the brain, you will not get exactly the same, right? So you don't want to measure that, because if you are doing EEG or whatever, you will get things different, and everything will be a little bit different. So we do this drug test, and it has like 8 types of drugs that is tested with the urine. And the persons are informed. The participant is not like suddenly it arrives and you have a drug test. No, no, no. They know in advance, like, hey, do you think you're going to pass the drug test? And then some people cancel and some people come. Some try to hide it, but they don't pass it. No, I haven't, like, but it's positive. Like, no, I haven't. So it's kind of cool. And it's very common, I think, in the nowadays young people. The marijuana is very popular, right? I have not. Huh?
Not yet in Hong Kong, but it will be.
In the United States, it's kind of common. It's kind of common. I'm surprised, actually. In the United States, I have seen a lot of, which is kind of strange for me, because I've been in Germany, in many countries. I didn't have the situation to find healthy participants around. It was very easy, but in the United States, a lot of them, many of them are medicated with anxiolytics, antidepressants, and you have a lot of marijuana around. So, okay. It's a suggestion. Probably here you don't have that problem, but you want to consider it, right? And anyways, although you don't do the test, you should write this in your consent form and in your ethics. This should be an exclusion criteria for your healthy participants. You don't want exclusion criteria, neurological problems, psychiatric problems, and drugs, recreational or medication. This is a suggestion, and I think it makes everything better for everybody, right? This other thing, when you are working with patients, the intervention is different. How the outcome will come if the person is in acute phase of their pathology, or is in a relapse, or is already recovered, or you need to take also this into consideration, because the effects will vary also depending on the stage of the disease, the pathology. Additionally to what they are taking, you need to know what dose they are taking, like how often, the dose they are taking, the speed of the increase or decrease of the dose, The combination with other drugs also is very important. And again, increase the risk of seizure induction. Like I said, it's repeated like, I don't know, in every page of the consensus. So it's really important. So for more information about drugs interaction, so go to your safety guidelines that are, next year will come a new, next year, it's each 10 years, I think it is. Next year, I think will come the new safety guidelines. They will say which other drugs or the experience they have had, you know, like all the big heads in TMS go together and they talk about their experiences and about review the literature and all this kind of stuff. You will have some new stuff there, but also talk to your clinicians. Well, children and TMS. We have already mentioned about that, done some wording about that. Single pulse and per pulse are a minimal risk procedure for kids. You can use it, so it means you will be able to measure excitability. No, will be more like a measurement procedure. You can do how excitable the brain is, but RTMS is not that recommended. Because of the developmental things that we already talked about, the brain is already in development, there are maturation processes coming. That when you were asking me about the age, actually I was kind of surprised. I didn't know. I knew this now that I was preparing this study. I haven't talked to anybody who has done to babies, but they, in the consensus, they talk about this, and I was quite surprised because they say that when the closure of the fontanelle, the hole that the babies have here, if you apply TMS, you can harm that part.
Yeah. And sometimes it's still soft.
Yeah, I was surprised. I was like, no, I'm reading wrong. This it cannot be possible. I'm not aware of any study that have been done with that. Maybe I'm thinking where it have been done. It have been done probably people that work with TMS and with babies maybe have worked with that. I don't know, but I found it kind of impressive. I don't want to put a baby in TMS, and definitely what I was surprised is that it can cause a damage, no? That you can create harm, you know. Oh, I thought no, but okay, so it means that in babies has been done, to my surprise. Same thing, the problem with the auditory canal. So TMS, healthy TMS, TMS on healthy children, no, because it can damage the auditory channel.
But here I just have a question. Just now you, this one you have told us is relation between the TMS and also the age. And you said that for children actually it's the motor threshold is actually higher. But so in my imagination, if children are more sensitive, the threshold should be lower. Or
no, because they.
Explain that.
Yeah, I said that it's because myelination processes that are going there, right? They are not completely formed. They are still in development, and they're probably the speed for the conduction time is completely different to a healthy subject, adult, that has been completely formed, and all the axons, everything is perfect, and everything is, the myelinization probably has finished, then it's still in development, it's not completely formed. So that's the problem.
That's also raises a question because for children, the motor threshold is higher, then we need to have actually high how can I say, impulse will be high, so that we can stimulate the children. And this actually comparison is more risky than, because usually the lower impulse actually has no risk, right? But for children, because the threshold is high, so we have to use actually higher.
Yeah.
So actually, it's more risky for children than for the adults.
Yeah, that's why it's not recommended in healthy children.
Yeah, sure. Yeah, that makes sense.
So it's kind of funny because I have done all these tests on my own, myself, and I remember when I was just like, you know, like everything is new, and then you try, and each time there is something new, you try, and people are around. And last year, I was working with, last year and the year before, I was working with children, which was very impressive, psychiatric kids. It was really sad because you could tell that the TMS was really strong and they do have a problem and they were kind of enjoying the pain, which is really painful. I had to stop many experiments because you could tell that it was really, really painful, and they just, because of the pathology, they were enjoying it. And they were bearing all this pain and all this, it was horrible. And I had my niece who came to visit, and I needed to do some testing, and she was in the age of the people that needed to measure, and I just didn't want to do it. So when you check at kids, I think you see things different. When we talk about us, like, okay, I can try on myself, or I try on you, right? You are adult. But when you think, okay, I'm going to put my kid in this, I don't know if I want to. I know it will not do a big deal, but I thought twice. And I consulted with her, like, would you like to? Yeah, I would like to have it. And I tried to delay the thing as much as I could. But I don't think it will really do something when the person is 18, 19. But I think when you think in kids, you really have a different thought about this. And you should, because it's your responsibility, yeah? Pregnancy, okay. So they worry like, okay, I'm pregnant and maybe something will happen. No, there has not been anything showing that the TMS will cause any damage, but it's recommended that the pregnant operator or a pregnant woman, the pregnant woman will not be measured, and the operator will be 70 centimeters out from away from the coil. Would be the recommendation. And unless you really have to do the TMS, it's recommended not to do it. And definitely what you will never, ever, ever do is to, where I have it, in the lumbar spine, to do TMS in the lumbar spine for pregnant. You will never do that. If you have to do it because the benefit of applying TMS is higher than the risk of the person, which we don't know if there is any risk, but if you say no, it will really be good for the person and it will be a benefit, so you do it, right? But you will never ever do it in the lumbar spine. And what I said, operators should stay 70 centimeters away from the discharging cord. Okay. Other factors that will affect TMS outcomes. That's really interesting because the first thing that I have here and that you also find in the consensus is menstrual cycle. I have never done TMS over menstruating ladies because the hormones change. There are many changes in the brain. You are measuring excitability, it will interact with TMS, and you will not have a proper measurement of what is really happening. So in Germany, I never did TMS over females menstruating, and it was stated in the ethics, in my ethics, and in the consent form. But in the United States, they don't care so much about it. I'm a little bit surprised. In the lab, I am, but it is definitely stated in the consensus. It's not at risk. It's not at risk. It's not like the person suddenly will have more blood or whatever. No, but the outcome will be different because there is an interaction. You are measuring excitability. There are some changes going on, so you will have some differences due to this measurement. So you want to consider not to do it. Not only that, I think there are some studies if you are working with memory or with certain cognitive processes. There are some studies that show that if the person is during this period, there are some changes in memory. But of course, you have studies showing yes, and there you have studies showing no. But for TMS particularly, I wouldn't do it. No, I don't do it. I take into account this, and I write, when was your last period, to know where is the cycle, the stage there. Yeah, it's a recommendation. You can do it as you wish. But as I was saying before, many people say, why I cannot reproduce your study? Well, because you are not reproducing it. Because in the labs I have been, they don't do TMS in menstruating women, but in other labs they do, and maybe, who knows, maybe this is a factor. And it's a factor because sometimes it's so difficult to find subjects that are male, and for TMS, mainly we have a lot of females coming. So you need to take this into consideration, and when you are doing your study, try to have balanced male and females. Important age. Now we know the age is completely, it's different. You have TMS interaction different with age. Levels of anxiety or the mood. When the person comes angry or something, you do have a different MEP reading. I can tell you that. In the beginning, when I started working with this, I remember that one of my mentors told me, if the person is angry, if you fought with the mother, you will say it in the MEPs, and you do see it. Like you have these big peaks or this kind of things. You do see that, and if they are tired, you see it. If they are falling asleep, you see it. You are in the back part, but you see it in the EMG. It's very clear. Sleep deprivation. This is very important. There is one case that was reported as a cause of seizure, and it was a case of sleep deprivation for someone who did a trip from one country to the other, and he didn't sleep well, went to do TMS, had a session, experimental session, and had a seizure. So keep an eye on that. The person didn't have epilepsy before or anything, but it happened. So probably the level due to sleep deprivation is not known, but it was reported. So if you have someone who has not slept, don't measure. I normally, when I have my participants, we keep an eye on this. How many hours did you sleep? How many hours do you sleep normally? That's very important to know. If they are partying, please cancel the study. If they are the night before drinking and partying and going at 5 a.m. and then the experiment is at 8, so better not come. I will appreciate if we reschedule. So thickness of brain layers, I put a question mark because how can you measure that, right? But definitely it affects. We talked before about that, right? There are some models that you can check. Some groups working on that, so it's a factor, definitely it will affect with TMS effectiveness. Brain atrophy, neurological and psychiatric illness. That's why in your study you need to write that. That is an exclusion criteria. Well, it's my suggestion, you don't have to, but better if you do. And if they have done previously TMS studies. What has happened, what they did. When you are working with, we call it professionals. When you are working with professional people that have done TMS more times, it's kind of pleasant because they know how it is, it's kind of easy. Yes, so it's good to know. Dosing. So questions?
Dr. Gamboa, can we actually have a sample of one of your typical consent forms? As I see, there are so many actually side effects and also terminology shall be actually included in consent form. So how would that be possible or not?
There are some examples I sent of consent forms that you can check. Yeah. And I think mine are in German, but I found some online and I was checking and I think these are quite good. So you have two examples because I wanted just for you to know how to start. You know, don't copy exactly what you have there, of course. But there are some online and another one I had. So you can check and then I wanted you to have the structure. And I'm really impressed with the way they do it in the United States. It's very precise, very detailed, and very good. They take into consideration the information they should give to the participant. Probably too much because, as I said, I would be scared. But it's good because then I know all the information and I know, so in the lab I am now. And then I know what are the risks and then I can do a very well-informed decision. So yeah, you have some examples. And I thought that what we will do is if the group was big, part of us will work on TMS and the other part will work on the consent form. So checking that and checking what they have to do, because you need to know this consent form. It's not like you write it and then you give it to your research assistant and then he give it to the other person. No. You need to read it and the person who is gonna So anyone working on the project needs to know by heart this. And they need to know by heart the risk and everything. I have had the experience that I was working with some other people, students. And I was guiding them to do some experiments that were experiments I were leading, well, I was managing. And they were doing the recruitment. And I always, if I have to measure, if I had to be there, I always arrive and hi, blah, blah. So, are you free of this? You don't have this, you don't have epilepsy? And a couple of times I found that they didn't do the screening correctly. And then I asked for this. I said, you need to know this by heart. You need to know by heart. You need to know what are the things that you should not allow in TMS. So not only read it, not only have it in written, you need to know it so that you are safe. And I spot some of these situations, have to cancel the session, of course, and talk to my student and say, no, you need to know it by heart, read it, and each time you talk to your participants, please start again. Before bringing the participant to the experimental session, talk to him or her over the phone. Inform. If you can send the information online, send information online, and they need to read it. When they are here, they need to sign it. But when they need to sign it, you have to go with them, that you need to go through the whole document page by page, saying everything you are saying. That they don't say, I know I didn't know this. You didn't tell me. You don't want to do that. It takes a little bit of time, but I think it's fair, right? You would like to know that, right? So just try to be as detailed as you would like it to be with you. Safety is very important. So about the dose, how much TMS we can apply? So you need to take into account 4 fundamental parameters that are train intensity, frequency, train duration, if the train lasts 1 second, 2 seconds, 3 seconds, and how often I am sending it in my trains. 4 seconds stimulation, 8 seconds break, 4 seconds. We will talk about the different parameters tomorrow. And also you need to know that when you are going to use this machine to program your own protocols, which you can program your protocols here. I'm not going to give you all the protocols because that's very easy to find online. You are interested in a study when you want to study, I don't know, patients with anxiety, which are very few actually. So anxiety is not a good example. Depression, for example, and they are using certain protocol. And you want to reproduce that, but I recommend only when you are doing TMS, if you want to reproduce something, you need to have an extra question that probably is behavioral and not related to TMS, because you never know if TMS will work. So always have a backup question in your hypothesis in a way that you make full use of all the experiments. And just get that paper, which protocol they are using, and try to reproduce it here, which you can, because this machine does a lot of cool stuff. Other parameters you need to take into consideration. The number of pulses you're applying in total per session. How many sessions per day you want. If you want to have 2 sessions, 3 sessions. I have seen this case for patients in neurology, where they have like a session in the morning, session in the middle day, and session in the at night. Kind of crazy. I have seen this also in one study I know, because I talked to one of my colleagues was being part of a study, TMS, and we were TMS people, and she was invited to be part of this study, and she was so dizzy in the end. She had like several types of stimulation during the day, and she just was feeling horrible. So you need to take this into consideration as well. How many days per week you want? How many weeks you want to do this? For example, for depression study treatments, it could be 1 month, 4 weeks, 5 days per week, and I think it's 1 session per day. So you want to consider that. And how is the frequency? Okay. Okay, this is important. We have talked this morning that we use the motor threshold as a guideline, as a guide for what type intensity of stimulation I'm applying. But then I have my motor threshold that is a value X, and from there, from this value, I can play like go low or go high. How much I can go high, how much I can go low. So they accepted so far that is reported here because at that time when they wrote this consensus was what everybody was doing. Probably now it will be a lot higher. Is 130% resting motor threshold. So you have about if this means what this means for the ones who were this morning here. If I can apply 130% resting motor threshold, so I find my threshold. Supposedly, you suppose is 60% of stimulator output. So the threshold would tell me how much is the intensity of the stimulator, right? A value. The value could be from 0 to 100, my stimulator. So 50% of the stimulator output, 60, 80, 70. Just suppose I realize that my resting motor threshold, to get that resting motor threshold for this person here, I need 60%. And the maximum I can apply is 130, so what would be my maximum to apply in a treatment or in a research question? Is it just simple mathematics? 30% of 100 or 60? 78, right? No? Well, I did it with the maths. So you can apply the only 130%. I have seen, I think, 140. So you can also, when you are going to do a study, what you can try to do is some people use just one fixed threshold for everybody. For example, 70% stimulator output, and everybody will receive the same stimulation. It is safe. Well, it has been done. You can do it. But it's not individualized, right? So as long as it is inside this frame of 130 resting motor threshold, it could be used. But then is what they are saying. They are saying you cannot determine the motor threshold, so you can find the threshold taking into account the measurements of the population you are measuring. I have this group, you are all participating in my study, and I couldn't find her threshold. So what I will try to use is a value that is common to this group. Yeah. So as I said, in some research, you can see some studies that everybody is stimulated at 70%, for example, because they have found that with 70% is like more or less the average. I can get this effect, and then it could be valid. When all these thresholds are being calculated for motor area, but when you are doing the stimulation in areas outside the motor cortex, you don't know if this stimulation is actually the right intensity. We don't know if we will get the same effect. We don't know if the right intensity. So it recommended that you adjust for this new area you are going to stimulate. This can be done by modeling. We already talked about this. Or it can be, we can use the Stokes formula, right? So you have this formula, and then it says is the adjusted motor threshold is adjusted motor threshold percentage is equal the motor threshold I got. For example, 60 plus 3 times the area I want to stimulate minus the distance of the region I want to stimulate minus the distance of M1. But which ones are these distances? I have here this table that is from the paper of Stokes. You have here the reference, you can check it. So here you have the difference between the different regions and M1, and then you just need to do is to replace this value here for the value here, and then you will get a value, and then you will get here a value that you will change in your simulator. And
question, So the multi-threshold, is that active or less active, right?
Depends.
Depends. Okay.
It depends on which protocol you are using. Many of the protocols, most of them, I'll say, use resting motor threshold. But for example, for TBS, for theta burst stimulation, you use active motor threshold. So if you have the active motor threshold, you can do the conversion in active motor threshold. But normally the active motor threshold is like 10%, 20% less than resting motor threshold. So it'll be kind of similar, just a little bit different. So this is a note which I thought it was important to write. Protocol safe for M1 must be safe in non-motor regions because M1 is highly excitable. So if I'm applying a protocol over M1 and, well, this is you get this conclusion, right? If it is safe for M1, so it will be safe for other regions. It should not be different, is what the conclusion they have reached. Okay, so let's talk about ethics and regulations. Any question?
So if the TMS has so many side effects, so why would we adopt the TMS? I mean, as compared to some of the similar tools. So why, what is the major benefit of TMS as compared to other tools?
Which other tools?
Similar tools. I mean, if we try to check the brain activity, especially a lot of tools. So if TMS is there,
but what compared to what?
Compared to other similar tools for which you can measure those like brain activity.
It's more than a measurement.
Yeah, because with TMS you are not only measuring, but you are modifying modulating the excitability of the brain, which is what makes it a powerful tool. So I can excite a region, and then this effect will last 10, 15, 20 minutes, and then it will, it will tell me things about that region. I can study, we'll see tomorrow, that for example, virtual lesion, I can try to shut down one area. Doesn't work like that. It sounds cooler than it really is.
Shut down an area?
Yeah, it's kind of, you create a virtual lesion, like if someone who has a lesion there, like a patient with a lesion there, so what you try to do is to inhibit that area. You don't shut down. I'm just being extreme just to create drama and to show how cool is TMS, but no. So actually, what the thing is, you can try to change the excitability, to inhibit the cells there, so that my region doesn't perform as good as I would like it to work. And then I have a lesion there, right? I have the possibility with TMS, but I don't have it with EEG or MRI or anything else. So the power of this is that it allows me to check regions, to see how they interact, to interfere with activity. You see, it looks super cool, actually, but then you are going to do it and you see you suffer so much because everybody doesn't react in the same way as you want. So you get some effect with 8 people, and then from people 9 to 13, they are completely opposite. But this is the power that you can intervene, you can try to change behavior, which you cannot do with anything else.
So it means that it's like if I shut down one part, like for example, prefrontal area, so like prefrontal area, I'll try to shut down it, and then try to see whether or not this person's still working or not. The TMS will be suitable for that.
Yeah, see, for example, I'm going to tell you one of my experiences with the MS patients, right? We were trying to create a virtual lesion with TBS, theta burst stimulation, what type of protocol we'll see tomorrow, that is known to be inhibitory. I gave you the class already, so I don't need to mention it tomorrow, but then we're trying to create so people that have multiple sclerosis, they have like some lesions in the brain, right? The interesting thing is that cognitively, if they are relapsing remitting, normally they were cognitively perfect. And the question is why? Why this happens? How can we, the working memory in them is equal like someone who is normal. Obviously, it needs to, probably is related to the area where the lesions are happening, right? But the interesting thing is that the brain recovers. So we were trying to see working memory, and then what we want to see is if we were able to, as they have so many lesions in the brain, if we apply this stimulation, the brain will be a little bit, it will be more difficult for the brain to be able to keep up with all the load and to perform a working memory task. You understand that? Because it has many lesions, so it's trying to keep up with all the activities that are coming, because they are perfect. They are perfect. They are perfect cognitively. If you compare one, which I did, healthy with the participant, there are no differences between them behaviorally. Psychologically, it's different. They think they are different because they know they have MS, but in the test and the paper and all the tasks, I never told them, like, they are doing the task. I'm not saying, yeah, you are performing. In the end, I did tell them. Because they say, no, but I know I'm not that good because I have MS. No, they were normal. So we stimulated the solatral prefrontal cortex to try to impair their working memory. It happened? No, it didn't. And it didn't probably, I'll tell you tomorrow why, things that you need to take into consideration when you are doing your experiments. But the idea behind is that I create some instability there. I inhibit that region, so the brain needs to have more resources to be able to perform correctly my working memory task. You understand? When you do it in a healthy subject, you will not have that problem because the subject doesn't have any problem in the brain and can compensate easily. So you wouldn't expect to see really a big drop in their performance, right? So you can use TMS for several things. You can use TMS to check, okay, I want to see working memory. If working memory is connected to parietal, or if parietal region is related to working memory, so I apply one stimulation method that will make this, inhibit this area. There is a decrease in reaction time, there is an increase in reaction time, there is a decrease in accuracy, there is, you try to check all these things with TMS. You cannot have this with any other method, like imaging or no. That was your question?
Yes.
Okay. Ethics and regulation. Research and clinical applications of TMS must follow the 3 basic ethical and legal requirements related to studies on human subjects. Informed consent. Again, I have been talking all the time about the informed consent. You need to have a very nice informed consent where the people are really informed about what they are going to receive. You need to know what is the risk-benefit ratio. Is the benefit higher than the risk? That should be always something that should be in your mind when you do for healthy research or clinical studies. And fairness and equity in research participation. I think yeah. So this means that you are working with all type of population and not only with certain population. Yeah. In United States, now I'm working there. I've been working in Europe mainly. And I have noticed that the ethics committee constantly asks for reports. And they are very aware that we have all type of population. In Germany, that was not that extreme, but we try to have all type of population. But in the United States, they count how many Black people you have, how many Latins you have, how many. It's kind of interesting that they try to include everybody in the study. And we need to report how many background people, the racial background, everything you have. Like you are including everybody, and everybody is like you can measure, no? And not only what we talk about this. Informed consent. People taking part of the TMS study or clinicals or research need to know about the potential risk, and so they are able to make an informed decision. I'm not tired of saying this because I did have the experience I saw some group that was not doing this because they thought that if they were doing this, people would not participate. So it was kind of irresponsible. It happened just in the beginning. Then they stopped doing it, and then everything started to go right, obviously because the ethics committee is always paying attention to this. So it's very important that you inform your people. Children and mentally disabled persons require a legal representative in charge of making the decision. So when you are working with children or with people that have some conditions, it's not like they are gonna sign them themselves. But you need to know when you are working with children, you have the consent form. The consent form, well, as we did it in Germany, was the father, the mother, and the kid. The three of them need to sign. It's kind of cool, right? Because you protect the kid. So it's not only the parents. They say, yes, he's going to do the study. No, 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 no. The kid need to sign. He needs to sign also and say, yeah, I agree. And the consent form, how it is written, it should be in a way that he can understand. And I remember I was trying to explain TMS to the kid and try to put like in a colorful way that he can understand what plasticity means and all this kind of stuff. And he would check like, no, they don't understand. And they're like, you're trying to look words for, you know, how to say stuff that they can understand. Like it could be comics or whatever, but they need to understand. It should be approachable for them. Very important. The form must list all the procedures, risk, and discomfort of the study. That's why this one-page consent form will not work, because you need to talk about it. You could have headaches. It has been reported in 40% of the people with, you know, all these things I'm saying here. You need to use this information in your consent form. I know it's a lot of work, but once you have done it once, you have a template for all the other studies. So you have to do it just once. If you are working together, or if you share things, just you can share stuff. You don't have to do it 10 times. Of course, if you are changing protocols or whatever, you need to adapt. Risk-benefit ratio. Again, benefits must be greater than the risk in both research and clinical trials. And what I said before, the participation in the study on the therapy should be equal for everybody, and it should be like everybody can take part of it. And you don't go only to people that need the money, you know? So I need to do my TMS, and I know that it will be easier to go to the student population that have no money, and I only go to them because they will do it for money to get some money to go out or whatever. No, that's wrong. You need to advertise everybody. If the people want to come, will be because they want to come and not because they need the money, you know? Which I have had. I have this situation of people that only come for the money. And they come and when they come only for the money, they come just to one session, they don't finish the study. So you want to really, but okay, apart from that, this really talks is about not only going to the people that you think you will be able to convince to do the study or to take part of the therapy. That's incorrect. You need to go to the general population, all type of economic levels and all kind of racial backgrounds and all, yeah. Managing emergencies. Okay, we're almost done. I don't want to run in this part anyways because it's I think the most important part to start the TMS study, because it's really, as I say, it should be compulsory that anyone who is coming to do a TMS study reads the consensus. It's really important. When I started TMS, well, actually, it's going to be recorded, but it's just a silly experience I had. I did have an accident and in my head in a motorbike, and I was unconscious, and I was like 1 week under observation and all this kind of stuff. When I started TMS, nobody asked me, and I was like, yeah, I'm going to do it because I want to test everything. And as I mentioned in the morning, like I wanted to do all type of stuff, blah, blah. But there is one stimulation particularly that when I was receiving this, I was feeling really bad. And then I started to feel like this discomfort. I don't know what, because I'm really open to test all kind of stuff. And I started to feel like really bad, you know? And it lasts like 1 week, my discomfort, it passed. I then read the consensus. It was, I think, like the first month I was doing this when I started. And I read the risks and I said, oh my goodness, I shouldn't be doing this because this is a contraindication. If you have been unconscious, if you have had a trauma in the head, you should not be measured with TMS. Did something happen to me? No, really, but it was my discomfort for 1 week, and I don't want anyone to have that problem. And I don't think you want to have this problem, like you wouldn't want to give discomfort to someone for 1 week, or 2 days, or 1 day. You don't want to have that. It's irresponsible. So I recommend that if you're going to have students coming to do TMS studies, it's not bad that the first thing is thank you very much for accepting your consensus. Read it, and then we talk about it. So they know all this stuff. After that, I said, no, I'm not doing more TMS. I do some testing on my own when I'm testing the studies. But I am not part of any type of TMS study anymore because I'm anyways a contraindication. It's a contraindication to have a trauma and to be unconscious. Yeah? When you have doubts, again, consult your neurologist or your doctor associated. So, managing emergency. Each TMS lab must have a program ready to deal with syncopes and seizures, compulsory. That is a must. When people start TMS, they need to have a training about that. After this workshop, I recommend that you bring someone that gives a workshop. It will take probably just 1 day, and they will teach you what to do in these cases as an expert that will tell you what to do, how to handle the situations, show you the different types of seizures and all this kind of stuff. And in your TMS lab, you should have, as I said, the emergency numbers and all this kind of stuff. Everybody should be familiar with it, not only like the leader or whatever. The leader should know this, and it's the responsibility of the leader of the study to know it. But it's his responsibility, her responsibility to teach, to train their people, okay? Life support equipment should be available when doing RTMS procedures. So that bad is, nothing will happen, but you should have this kind of stuff near. Everybody should know where it is for safety. And efforts should be made to prevent complications during episodes of seizures and syncope. This is very important because there are some labs that are really crowded, for example, and then if someone is having a seizure, what you need to do is you need to allow the person to have the seizure, right? So what you should do is to give space to the person to have the seizure. You don't want to put anything in the mouth. You don't want to move. No, when they have the seizure, you need just to remove everything around so that they don't hurt themselves more. That's the only advice, suggestion I can send. And I talked to a neurologist before that I said, you can tell them this just to tell them something about this, but obviously you need to have your own training. But the most important thing is having cables and things on the floor and all this kind of stuff. No, you need to have a space where actually this can happen, yeah? When the seizure has passed, so you go and do stuff that your doctor will tell you what you have to do. In each, also, in each part, you will do it differently, probably. Yeah, but what is basic is that when person is having the seizure, you don't want to hold the person. You don't want to leave it there that it's going to fall. You don't want to leave things around, so just empty, put her in a space, allow it to have the seizure, and it will pass, and then do what you need to do, put it on the side or whatever. But I'm not going to say more. Talk to your doctor. But you should prevent any complications, okay? What I already said, important note is that people experiencing TMS-induced seizures must be informed that the frequency of seizure episodes will not be higher than before. Medical and psychological support should be provided to patients and normal subjects who experience TMS seizures because it's really, really impressive, so you want to do that. Credentials of the TMS operator. So who should do TMS? I have seen some people doing TMS that they have no idea about TMS. They have just seen, someone has said probably, you put the code like this and you just do it. And I find that really irresponsible because I don't know, it's a serious stuff. You could train, it's not like it's no rocket science. You don't need to do a master in it, but you need to have some knowledge about it. And so you should have some training, kind of the training we are having now. So now you have some knowledge, so there are some safety guidelines you need to follow. We can do some TMS now to see how you do this and some stuff, but you need to know this. It's not okay, TMS easy, because it's easy. put the coil, and that's it. Not only that, it's irresponsible. So provide training. One way to provide training when you have your students is once you know how to do this, and I would recommend to do that, is when you learn now, what you can do is bring 2, 3 people and do 3, 4, before starting your training, your proper experiment, test with other people. Train between yourselves. Come, do the test, take measurements, see how it is, and test things. Don't do the experiment straight away. Like, okay, she taught me how to put the coil, tomorrow I have my first measurement. No, that's irresponsible. And normally this data is not valid. So train, hold the coil, see how it feels, how tiring it is when you have to hold the coil for a long time. Fortunately, you have here a lot of stuff here which I don't use because it doesn't work sometimes. It's more difficult to try to accommodate the coil sometimes. So training is the thing. Once you know the safety measures, play with it and train among yourselves. Regardless of the type of study, if it is research or clinical, people should be properly trained. Neurologists or clinical physiologists should supervise clinical routine. It's irresponsible not to have a neurologist or a proper physician for clinical routines. In research studies, the PI should be trained and is the person responsible for the study. So I have my students here, and I'm the PI, and if they do something that is wrong, it will be my responsibility. So as it will be my responsibility, I don't know if here you can be sued, but in other countries you definitely could be sued, and I have seen it. It's horrible when a researcher is sued. It can last a long time, and it can happen just out of the blue because the participant thought, no, I thought you were a doctor and then I feel pain, but now I don't recover, whatever, it could be whatever. And it can last a long time, and it could be very bad for your psyche and your problem and everything. So you don't want to have that. Be responsible and train your people and be trained. A screening procedure should be checked by a licensed physician. And as I said, in my studies, I don't know how would you do it, but in all the studies I have done, always have a doctor associated to the study, always. In the consent form, you should have all the information about the doctor. The participant should have the possibility of talking to the doctor after, during, or before starting the study. They have the right, they should have the right, I don't know how you, because here the rules are different, but in Germany and United States, they have the right to say, I do want to talk to the doctor. I want him to tell me this. And if they experience any discomfort or whatever, they have all the information, they can contact the physician. Again, all TMS operators must be trained how to recognize and manage syncopes. Mainly, just keep calm. And obviously, well, in principle, then do whatever your physician told you to do. And all the possible complications that will come from these seizures and the syncope. I wrote here the list of contraindications. My list of contraindications in one of my studies is super long, like 2 pages. I tried to summarize this. Well, I put here history of seizures in first degree relative, any illness involving the brain, and really check that, like you want to check that. Medications, tinnitus, if someone has tinnitus, don't measure. For research, no, because you can make it worse. Pacemaker, intracardial things, no go for research. You don't want to, unless it is related to it or whatever. History of bipolar disorder or any psychiatric disorder, you don't want to have. Metal in the head, metal in the mouth is not a problem. Nobody asked about it. Like they ask, you ask see if you have metal in the head, and normally we say, oh, you have retainers. That's not a problem. Traumatic brain injury with loss of consciousness greater than 5 minutes, the story I told you about myself. So it's a contraindication, you don't do that. Pregnancy, no, because we don't know what can happen. History or presence of increases intracranial pressure, pumps or cochlear implants, cardiac disease, any lesion of the brain, with or without history of epilepsy. So really, if you want to do your research, do it with healthy people, sleep deprivation and alcoholism. This is the questionnaire that you received, I think, right? And this is also something very interesting, and you should keep in mind. Sometimes you are doing the questionnaire and you are talking to the person. And the person gives no to everything. But you have the right to decide if you want to measure this person or not. And I have done it as well. And you do it because you see that you might have complications in the study. You see it, and the person is too reactive or something. You also have the right to decide if you want to measure this person or not, and it should be stated in the consent form. On the consent form, you should say that the physician or the PI has the right, for whatever reason. You know, do you know what I mean? Like you see people that, I told you the experience. There was this person that heard I had several, heard the click of the coil and move all the body without the coil being near. Just because I switch on the equipment, I say, okay, we're gonna start just for you to know what TMS is, and I click and the person moved I explain, I'm gonna move this finger, you need to explain everything, no? What the procedure is gonna, and the person moved there. I said, no, and so I cannot measure because it's being overreactive. I haven't even put the coil was in the back, was like, I don't know how many centimeters far from the person's head. So would you measure this person? No, because you don't know psychologically what effect it will have. So don't measure. You will see. So you should write also in your consent form that. Even as it said there, but this is just the questionnaire. If you answered yes, it doesn't mean the person is not going to be measured. It can be measured, but obviously it depends, no? You need to know all this information. And that's it.